to our first guest speaker. If you don't know, I'm Miss Younger, and I am their assistant. So these three gentlemen have started HOSA, and they are going to introduce our guest speaker to you. So thank you all for coming.
Hi, so my name is Karun. I am the president and founder of HOSA. These two are my wonderful people that are on board. You guys can introduce yourselves.
I'm Andy. I'm also a co-founder and the vice president.
Hi, I'm Noah, and I'm the secretary of HOSA and co-founder.
Yeah, so we just all wanted to thank you so much for coming out on a Friday evening, just grabbing food, have a good time, listen to a nice presentation, learn more about a topic that you may know about or may not know about. And so let's just get right into it. I'm gonna hop out and we'll have our lovely first ever HOSA speaker, first guest speaker, come do a nice presentation for everyone. So thank you guys for coming once again.
Thank you, Corinne. Well, Corinne knows because he helped fix it. So you may know me. I'm Aviva's mother. I'm also the proud parent of two other Rochelle High School graduates. Class of 19, class of 21, and hopefully class of 23, who's incredibly embarrassed that I'm here today, but she's volunteering elsewhere. Who here knows an anesthesiologist? Yeah, you do? Really? Family member?
No.
Neighbor?
No.
Do you know what that person does? Do you know what the person does?
Kind of.
Kind of? What do they do?
I mean, the person is asleep. Like, before sleep.
Anybody can put you to sleep. I have to wake you up. Right? Okay, so so you know this person's name?
No.
Okay, so most people don't know who we are. And we are only 6% of any medical school class will choose anesthesia as a specialty. And I was not one of those very smart 6%. There are no doctors in my family. I was going to become a pediatrician. That was all I knew. And I knew I was going to become a doctor when I was around 7 or 8 years old. Many of you here probably know. I was briefly a teacher because my aunt was a teacher and I wanted to be just like my Aunt Mary, but then I realized I was not going to be a very good 4th grade teacher. I briefly, after that, wanted to be an astronaut, and then the little voice was, you need to do medicine. So I applied to medical school as a pediatrician. Okay, small child, goodbye. And so it was not a direct path, and so I'm going to tell you what I did. And I think you're going to understand that whatever you're going to plan now is going to change. And situations will change, you will change, and the plan right now might become a very different plan that you're really happy with. Okay, what I wanted to talk about, which would require a weekend symposium, a very, very, very brief history of anesthesia, and how I'm here as a very happy anesthesiologist. I love what I do. I've done a lot of different things, but every day I love what I do. It is a huge rush anytime you take care of somebody. A lot more fun than the other plans I had, and we're going to do a little mini workshop, I hope, on airways, because you all have heard about intubation. You know what that is. You think you know what that is. You will know too. Okay, 2 topics I am not going to talk about because Corinne said that we don't have time. Anesthesiologists dictate outcomes for surgeons, and what we do affects how long a patient is going to be in the hospital, how much pain they're going to be experiencing, whether they're going to have pulmonary complications. And basically, as I was telling Ms. Younger, if I am going to just put in an endotracheal tube, put you on some vapor, wake you up and give you some pain medicine by vein, that is 1990. We do really cool blocks, pain blocks, and we can essentially get people through an anesthetic, a surgery, an open surgery, without the use of opioids. You've heard of opioids. Okay, and in my world, seconds matter. It is not, some people may say, hours of boredom punctuated by terror. No, but it's usually pretty smooth. With a lot of examples and analogies to the airline industry, we have simulators, because basically anesthesia is very, very safe. I have like a pulse oximeter in there, which It was only invented in 1985. And since that time, there have been a lot of innovations, a lot more safety equipment, and if you're not convinced that this is the coolest specialty by the time I'm finished, I'm not doing my job. Okay. If you want to know more, another thing Corinne says I can't talk about, we are very concerned about making sure that our specialty reflects the patients that we take care of. And so there's a huge DEI initiative, and there are a lot of websites where you can find more. I would direct you to the ASA website, the American Society of Anesthesiologists. And you should also know about the American Medical Student Association, where there are a lot of resources and information. Okay, what did we have? This is basically the history of anesthesia. We've had opium, we've had poppy plants since the Sumerians, 4000 BC. We're talking about well, I don't know how they were talking about it, but we know that poppy plants have been in existence. That's morphine. And there's been alcohol, fermented everything since the beginning of time. In the 1840s is when local anesthetics, inhaled anesthetics, ether, was discovered, and I'll tell you a little bit more about the controversy there. In the 1860s was local anesthetics, so like lidocaine, bupivacaine, there are many others, or the benzocaine that the dentist might use. That's around 1860. And people were having surgery, and people were being put to sleep somehow, I don't know how, but it wasn't until 1910 when a guy named Sir William Osler, who did a lot of really good things, said, you know, here at Hopkins, we think that there should be some kind of training, because it typically had been the medical student rotating on the surgical service who would do something to make sure that the patient didn't move and didn't remember. And moving on, 1930s, intravenous anesthetics. Okay, so these are our benzodiazepines like Valium, and hypnotics. You may have heard of pentothal, and then propofol. Okay, you must know this famous picture. This October 16th, 1846 affects what I do every single day. This is the first public demonstration of ether. John Collins Warren is one of the big monkey mucks at Massachusetts General Hospital, and here he is trying to remove a tumor from the neck of somebody. This is a place, this amphitheater still looks the same. This is Massachusetts General. It's called the Ether Dome, and this is where a conference such as this would take place. Kind of cool. But this picture makes me very, very nervous, because the surgeon is going to operate on the neck, and the guy, can you see him, the guy with the flask? That is a dentist. That is a dentist. That is William T.G. Morton, who would have you think that he was the first to discover general anesthesia. There are a whole lot of things wrong with this picture. There is no pulse oximeter, there's no blood pressure cuff, there's no oxygen, and he was going to be operating on the neck, which, if you can take a look here, there are a lot of very important structures there. Very scary. Okay, this is the guy who really discovered anesthesia. He was a surgeon and a pharmacist. He trained in New York, Crawford Long. The problem is he was in Georgia, which was just not as cool as Boston. And ether was kind of a party drug. There were things called ether frolics. He was a pharmacist, and he was a surgeon, and he's like, you know, maybe I could use that too. The problem, and this is one of the points you need to take away from this, he was scooped by a dentist. He was probably the first. We all accept he was the first. But he was doing really cool stuff, but he never published it. So he got scooped by a dentist. File for future. Okay, who am I? Okay, well, this is what I do. I am now a general anesthesiologist. I work at a hospital called Lawrence, which has been renamed NYP-Westchester. I did a fellowship in pain management for a year. I practiced pain management for 11 years. So I'm going to tell you why I had to leave pain management. I think I started telling you I thought I was a pediatrician. And then I went to medical school as a pediatrician. I wrote my essays on why I'm going to be a pediatrician. And I could not take care of sick kids. I could not. I said, well, what am I going to do? There are no doctors in my family. I don't know. Adults. I'm going to take care of adults, because adults do bad things to their health, and they bring on problems. I can deal with that, I can take care of it, I can maintain my professional distance, and I'm gonna be great. But in the back of my mind, there was this idea that one day I might want to be a parent. I had no idea. I had not met Alan Segal until the year 1999, and right now this is 1989. I had no idea, but I knew I wanted to be a parent, and I had realized one thing about myself, which is a take-home message for you: know yourself. Things are going to change, and I realized I needed to restrict whatever I did, and I need to be the best. I need to be the one that's like, yeah, Dr. Segal took care of me. Yeah. Not like I'm such an egomaniac, but I don't want anybody to ever think, oh yeah, she works part-time, yeah, she's got kids, she's distracted. No, I needed a field that was gonna be focused, not changing very quickly, like internal medicine, which is a wonderful field, but the guidelines for treating hypertension are changing all the time, the new antibiotics all the time. You need to be reading, and I love internal medicine. I became an internist. I did 3 years of residency as an internist at the University of Rochester. I highly recommend it. Why? They invented the night float system, which was a breakthrough where if you were on call admitting patients, there was some guy that was gonna come in at 7 o'clock and say, hey, I'm gonna take care of all your hospitalized patients. You go take care of the new ones, and then you should get enough sleep. They invented it. They also invented something called the biopsychosocial model, which is you're not talking to like the MI heart attack like in room 4, you're talking about Mr. Jones. And it's an incredible institution. So there I was an internist, minding my own business, and medicine people are more thinkers. These are the intellectuals, they are the detectives. They're gonna say, well, you know, what time did you finish eating the tuna sandwich before you started to feel nauseated? And then when did you have the fever? And that was okay, because they're kind of like detectives, but they didn't enjoy what I discovered I enjoyed, which was the ICU. And I realized I was good with my hands. Who knew? I don't know. So putting in lines and things in the ICU for me, I was like, yeah, no big deal. But those guys were like, okay, we're gonna do it. It was a very different approach. I realized I had skills that I never knew before. I had a life-changing experience. I met a guy named Jim Zelatos, who was the critical care fellow. I was minding my own business. I was a second-year medicine resident, and I was going to go into critical care medicine, which for an internist is 3 or 4 years of pulmonary and critical care training, treating asthma in the office, and sometimes intubating, sometimes taking care of very sick people, because I liked hard data. I thought critical care medicine was going to be the answer. I didn't have to wonder if somebody told me the truth, or whether they didn't. Did they take their medications? Or I had full control, and this was why I wanted to be in the ICU until I met Jim. And Jim asked me what I thought about asthma, and I was like, oh, I don't know, treating asthma in the office, that's scary. I don't know if I like that. And by example, he could handle the sickest patients. He could go to the burn unit. He could take care of very, very, very sick people. Intubate, no problem. Very sick, no problem. And I realized that I should be an anesthesiologist because he told me I should become an anesthesiologist. So what did that mean? I finished internal medicine, and then I did 3 more years of an anesthesia residency. Turns out he's been doing this a lot, and I've met other people. There's a guy in my group who also, 12 years after me, met Jim Zelatos in the ICU and also left internal medicine and became an anesthesiologist. So he does this. So what happened? So I was an anesthesiologist, and I was in Boston. Boston was really cool. And I thought I was dating the person I was going to marry until he broke up with me. Sad. So sad. Obviously, this was not Alan Segal. I think it was fun. But at the time, I was doing my pain management rotation, which is a month. And I thought, my heart is broken, but I love this. For me, it was internal medicine with cool blocks and cool tricks. And I could wear my street clothes and my big girl shoes. And So what did I do? I did a pain management fellowship for a year. And then I came back to New York. I'm originally from Queens. And my first job was at Cornell. All right, that was 24 years pretty much summed up. One of the best positions I ever had, and I will come back to, was I was the pain fellowship director at NYU. We were doing pain studies, and I really enjoyed teaching. I don't do that anymore because I left pain management. I'm not going to talk about this. I left pain management. Why? You heard about the opioid epidemic? Who started the opioid epidemic? Doctors. Doctors. Okay. Look up the name Russell Portnoy and his supervising attendant Kathleen Foley. They did us a big disservice. So I had come back, I had trained in Boston, doing blocks, not an opioid heavy practice. I came to New York where the mu receptor, which is where morphine works, was discovered at Rockefeller University. There was a big competition between a whole lot of New York City hospitals, but the mu receptor is a New York City invention. I realized that I inherited a bunch of patients in the practice that were on a lot of stuff. They were on fentanyl patches, they were on MS Contin, they were on OxyContin, they were on a lot of stuff, and they were not getting better. I didn't like it. And we knew that this was not going to end well long before you and the news figured out. And so I had to leave because I just didn't want to be complicit in it. So, lucky me, did a whole lot of other training. I went back to the OR and I love the OR. Okay, a bit about me. I went to Bronx Science. I'm trying to find Bronx Science here. I think that you guys are having a very similar experience to me because you have found your people. What did it mean I found my people? I learned that the best way to get A's is I needed to be studying with my friends. And that is a truth that served me very well, especially in medical school where in medical school I was a little nervous in the beginning and I didn't want to study with anybody else, and then I realized my grades were going to be a lot better if I studied with friends. Fast forward, in order to practice in your career you have to take boards, and that's just an exam, but like surgeons, anesthesiologists take a board exam which has a written. You need to score above the top 80th percentile or higher, and then you take an oral exam. Well, what is that? An oral exam is you're sitting in a hotel room wearing a suit with two men. Usually it's men, because there aren't that many women in my field. We don't do that often. You do that for 35 minutes where they batter you with questions, and then when they're finished with you, you wait 15 minutes, and then you do it again. That's anesthesia oral boards. The best preparation for the boards was studying with friends. Vital. Okay, moving backwards. My choices when I was in high school, I thought going to a women's college was going to be really cool. I had no money. Questbridge wasn't invented yet, but I would have qualified as a Questbridge scholar. I had no money. I was raised by my father, single parent, and I had younger siblings. I thought of going to a women's college would be cool. So it doesn't matter that I didn't choose Wellesley. I'm glad I didn't go to Wellesley, but I went to Bryn Mawr. Katharine Hepburn is an alum. She taught at my graduation. Kind of cool. I have legacy status at UPenn, and I am so glad I did not go there. Why? Because it has a wonderful reputation, a lot of history, but if you're a pre-med student at the University of Pennsylvania in 1982 at the time, your classmates were going to sabotage your labs. And it was very, very cutthroat. And your chemistry professor most definitely wanted to make sure that you did not get an A. And if you made it through Chem 101, your organic chemistry teacher was definitely going to finish the job. So I chose a very nice liberal arts education. It was all women, kind of cool, very different than Bronx Science, but nobody was sabotaging my lab, and I had a wonderful experience where my classmates celebrated each other, and I highly recommend if you are thinking this pathway that you should take a look. So for example, what does that look like? 92% of our class will get into medical school. Okay, well, 92% of what starting population? 92% of the ones that you remained after you weeded them out. Be very careful when you're looking at colleges for that. The other thing about me was I was very good at French. it's kind of easy to be good at language if you're at a high school for science and math. And I took AP French, no problem. I was going to be a French major. I wrote, and I chose Bryn Mawr in part because they were known for languages. And then I placed into an advanced French class, and I was really proud. Don't make this mistake, because my other friends who were pre-med, and one woman I never went to Sparkstone High School, she was also like me. She had taken AP French, but she said, oh, I'm not going to go into that advanced French class. I'm going to take it down a little bit, and I'm going to make sure I get the A. Okay, so what did I do? So I got a 3.3 in French, and I was like, oh, I need to get A's. I'm going to medical school. It was the same then, it's the same now. You need A's. So I also learned Italian, because I can get an A. It was fun. And I also took some music classes, because I could get an A. And then I come out of a very nice women's institution, and I am really well-rounded. I majored in economics. Why? Because it's science and math, and I can get an A. I also needed to have a backup plan. What if I didn't get into medical school? And I had fantasies of being a translator at the UN, but that was not going to happen. But I thought if I had an economics degree, I could find a job. So what happened? Okay, another thing you need to know about me. I finished high school when I was 16, and then I finished college when I was 20. And I was tired, and I took 2 years off, and I worked in a lab. I worked at NYU, and that research, so I was, maybe you know about microtubules and meiosis, mitosis, and the tau protein? It's kind of common now. It wasn't so common then, but I was purifying tau protein, got on a couple of publications, served me well. So then what happened? So I went to SUNY Stony Brook. Why? Because I needed money. And this was one of the most important decisions I ever made. SUNY Stony Brook was one of the newer medical schools at the time, and we had really nice, young, energetic faculty. And they all came from the University of Rochester, and that's where 8 of my classmates, I was in a class of 100, 8 of us went into internal medicine at the University of Rochester because of the motivating faculty that we had. Okay, so here I am. I'm a medicine resident. You heard about Jim. Jim sends me to Boston. I go to the Brigham. Brigham is not MGH. Brigham is friendly. MGH now. MGH cool. Etherdol. We call it massive general anesthesia. Brigham was fun. Really fun. They were inventing all kinds of local anesthetics, and one that we studied, which, get this, it causes a motor block but no sensory block. So you're paralyzed but you feel everything. Yeah, we used that. And then since I told you I had to do a pain fellowship, so I went next door to the Beth Israel Deaconess in Boston, and then I came back to New York. Okay, so why am I an anesthesiologist? And as I got older and these random things were happening, like, you know, I need to make a difference. Like, I don't want a desk job. I'm not a paper pusher. Don't like paperwork. Really don't like paperwork. And I realized that I need to be top dog. I don't need to be the chairman, but I need to have my reputation be solid. Like, oh, you were Miss Younger's AP Bio class. Yeah. So, and I realized that one day I was going to have kids. So, well, I didn't know I was going to have kids, but I wanted to. Internal medicine is a wonderful career, and I don't want anybody to think that this is not a wonderful career, but it wasn't for me. And I found that it was challenging, that it didn't matter if I knew every single study on hypertension, I knew how to treat this, that, or the other. If I could not persuade Mr. Jones to take his blood pressure pills, he was headed for a stroke, a heart attack, and kidney failure. I could not live with that. So I needed control, but I'm not a control freak. I really lost sleep over this, like knowing that people were not doing what they should be doing. And you'll talk about control. I, as an anesthesiologist, I can pick a blood pressure. I will make the blood pressure. people are bleeding, I know how to stop the bleeding. And resuscitation is really what we're all about. And I know how to do that. And it's all on me. It's not dependent upon any other variables. It's all on me. All mistakes are my own. I don't have to worry about that. There's other variables in the equation. And then there's what you guys talk about and think about, and I really encourage you, is the work, they call it work-life balance. There's no balance, you know there's no balance, it's Jenga. But there's an equilibrium. And for me, I'm on the mommy track, which means I work 7 to 3. You will typically see me in the afternoon. It was a challenge when I needed childcare because I needed to be bolting out of my house at 6:20. So I paid a lot of money for very good people to take care of my kids in the morning. But they grew up, they're fine. Okay, so we're going to go to basic stuff. Okay, I think I kind of covered it. How do you become an anesthesiologist? You go to college. Okay, what are you going to major in college? Whatever it takes to get an A. There's no pre-med track. It's a bunch of classes. You can be an economics major. My husband was a history of something major. And in fact, when it comes to interviews, you are far more interesting than a random chemistry major or physics major or math major. Cool, but if you could come in and you could talk about something in the arts, or you could talk, or maybe you were an art major, better, or one of my classmates, crazy, was a philosophy major. Fascinating. So, yeah, so you major in anything that you can get an A, and you should have fun. Pre-medical requirements have increased. In my day, it was a year of biology, year of chemistry, year of organic chemistry, year of physics, year of math, and English class. Now, you have to add a little more. You have to take biochemistry, you should take statistics, you may have to take sociology, and then there's this shadowing requirement, which is kind of a bear because of HIPAA and vaccination centers, but it can be done. There is a test that you have to take called the MCAT. You guys are thinking more in terms of SAT, ACT. It's called the MCAT Medical College Admission Test. You will prepare for it, and you will study for it. You do not take that test cold. And then I would highly recommend a gap year, and you should do research because it will only make you better. You will be able to understand the studies that you're reading. It will help you determine your own practice, reading papers. There's a lot of junk science out there. How do you know to discard a paper? Like, I think I brought you like my anesthesia journal. Some of those papers are junk, but if you understand statistics and you understand how a well-run study is, you're going to be good, and you're going to be able to, because eventually you're going to be on your own, and you're not going to have your attending supervising you as a resident. You need to figure it out on your own. There are meetings that you can go to, but there might be junk science there too. Okay, the other thing that you should do that I didn't know, pay a lot of attention on every subspecialty rotation. Anybody, and you should always ask, why did you choose this? You should also ignore the complaining residents. Residents will always complain, but they're not leaving the medicine field. There's a lot of complaining because it's hard work, but it's fun. And when you're a resident, you're being paid. Yeah, I had to look it up because I earned much less back in the day. It was a long time ago, but a resident is earning about $65,000 a year. Everyone. It's a national thing. You could be earning that $65,000 in New York, where it won't go as far as in Idaho, but it's kind of a job, but you're learning, you're like an apprentice, and if you screw up, there's someone who's got your back. So it's kind of fun. It is not a daunting, terrible, long, dark hallway with one long street. It is not. It's kind of fun. Yes, so fourth year of medical school, what did I want to tell you? Choose wisely when it comes to subspecialties. You should just ask, why are you doing this? What is your plan? Ask people why they're doing what they do. One of the questions, those were very good questions, by the way. Well, somebody had asked, was there a field that you wish you knew more about? I wish I had learned more about radiation oncology. I wasn't exposed to that. I kind of saw it, but I had my head in the sand, and I wish I had known more about radiation oncology, because that is a really cool field. And I think I covered this. Internship is always the first year of any residency. You can do an internship in surgery and then become an anesthesiologist. You can do a 1-year internship in internal medicine and really learn how to be a doctor and then become an anesthesiologist. I happen to have had 3 years of internal medicine and boards and stuff. It just makes me that much better. Nowadays, you have to do a fellowship if you want to do any of these specialties. Like, I don't do pediatrics. Children scare me. In fact, in my residency, remember, I could not be a pediatrician. Again, I had the choice between 2 months of training in pediatric anesthesia or 3 months. 2 months. Yeah, couldn't do that. Cardiac anesthesia, really cool, really cool. Big monitors. Very exciting. Patient doesn't know who you are because you get them, you do all this really cool stuff, and then they're intubated, they go to the ICU, they don't know who you are. So you pick that kind of a field if you like the tech, you like the ultrasound, you like the monitor. It's cool because we're pretty badass in the OR. But the patient will never know who you are. And then we are required to find the patient. If they're in the hospital, we always come by and say, "Hi, remember me? Huh? Huh?" So if it bothers you that your patients are not really going to remember you and they're not going to know your name, don't become an anesthesiologist. But if you know that what you're going to do is make a very meaningful impact, do really cool stuff, and really enjoy, it's a huge rush. It's a huge rush. Every day. You go into anesthesia. I don't know if this is a good one, but somebody had asked me about a typical day. We'll talk about a typical day. So pros and cons. I work with my hands. Like, if I developed Parkinson's disease like my uncle, I would not be an anesthesiologist, but I could fall back and be an internist. Keep your options open. But the things that we do are not discussed. If I got into trouble and I called for help, we are soldiers. I get the team. I needed help yesterday, actually, for somebody who had a ring spasm. We'll talk about it. Everybody comes, and we all know exactly. We're like, I don't know, like worker bees or something. We all know, like laryngospasm, full stomach. Everyone knows what to do. It's kind of cool. It's not a desk job. Not a desk job. And the cool thing is, like, I really am all over the place. My room could have somebody having fibroids of the uterus removed, followed by somebody having a gallbladder removed. These cases take maybe an hour and a half. Followed by, I don't know, colonoscopy. And it's really intense. And you're meeting people who are at their lowest, and they don't know who I am. But I have to come and I have to immediately get their confidence and say, "Hey, hi, I'm Dr. Segal, I'm the anesthesiologist, and take care of you. We're having a colonoscopy today." And then I have to immediately get their trust. There are things that we do. It usually falls into, "Oh, you put the IV in, I didn't even notice." That's the way you get a lot of confidence. We take care of one patient at a time. Great. It's intense. It's me, patient, and the surgeon, and the scrub tech, and the other, and it's a whole team. But I don't have, like my husband has, about 1,000 patients who call Alan Segal their neurologist. I don't get that. I don't get called at home. I don't get a lot of that. One patient at a time. So I made it clear. It's short term, it's intense, no long-term follow-up. So they may not see me again. Although, if you stay at the hospital long enough, sometimes you see people coming back and they're like, "Oh yeah, I remember you. Oh yeah, red glasses." Sometimes we get our follow-up, but it is, if you are the kind of person that wants to grow up with your patients and you want to be part of their family and you want to know how they're going to do, and you're not an anesthesiologist, because we have none of that. And it is not a team sport. It is, like I said before, all potential mistakes are my own, and I fix them. But if I get into trouble, or I get called to the emergency room, and I have a guy that looks like Santa Claus, and this is going to be a difficult intubation. 4 people, hands down, we help. Okay, so this is what, somebody wanted to know what my day looks like. My day usually starts at 7. I can't show you for HIPAA. But this is an anesthesia machine. We wear 2 masks. If you think 1 mask is bad, wear 2. Can't breathe, really can't breathe. But if you like tech, this is a very simple setup. This is an anesthesia vaporizer for the most common vapor we use. This is a different vapor. They have different physical-chemical properties. It helps to take chemistry and physics to know that because you get asked. Doesn't matter clinically, but these are very different looking machines because they have different vapor pressures. I'm neat. We are all neat. And if anyone, I got into trouble and someone saw, like, Thalia, what's going on? Here's all my stuff. There's my propofol syringe, nicely labeled. And here's some other stuff that I used. Mask, the syringe that I used to put in the drink. Anyone can walk in here and say, grab this, grab that, grab that. Monitoring, very cool. And we're all taught how to take apart these machines in training. And like the air industry, we have simulators that are involving this. We have simulators that take us through very rare kinds of reactions to anesthesia. Very rare, they're rare diseases. We need practice. This could have been a simulator, but it's not. Okay, who is this guy? This guy was the best thing to come out of the president that I did not vote for, the last president. Jerome Adams was the Surgeon General, and he came to the annual meeting of the New York State Society of Anesthesiologists, and he told us his story, so I will paraphrase. He grew up in Baltimore, really poor, raised by mom. Mom was working a lot, and he was doing bad things. But as he described it, these old white guys thought he was smart, and they encouraged him. And he gave us 2 messages. Number 1, mentorship. We need mentorship, which is half the reason why I'm here. The other half is Corinne said would be a good idea for me. The other thing he told us is carry naloxone. And I will show it to you because he also told us go to the pharmacy and get it. It looks like an EpiPen. But all of us, I carry naloxone. Why? Because when seconds matter, I'm not waiting for an ambulance if, God forbid, somebody's had an overdose or a problem. You get me. I give you Adams. Jesse Ehrenfeld. He is a Brigham resident many years after me. But he's going to be the president of the AMA. Cool. He's going straight to the top. So we want legislation and understanding what us, like the little guy, the anesthesiologist, those nameless, faceless people. We've got this guy. Okay, I picked a picture of Cookie Monster because he would be very difficult to intubate. I have no regrets. I love what I do. I can't imagine retiring, but I will eventually become old and decrepit and maybe not so good, and maybe my eye-hand coordination won't be so good. I love anesthesia. I hope that you will take a look at this field and see if it's for you. If I could do anything different, this comes from my husband. He's like, you should have never left NYU. You should have, and it's true. When I think about my career, as much as I love taking care of patients, it's not as fun as if you're in an academic practice where you're training younger people. It's kind of cool. I mean, it's like teaching people to drive every day because we do very dangerous things. But for me personally, I'm kind of an egghead. I like reading papers. I like talks. If I could do it again, I would have done that, but I don't know how I could have raised my kids and been good as an academic, because an academic is publishing and doing studies. I don't think I could have done it, but I have no regrets. But if I had a choice, I would have, that was probably what I was best suited for. You'll figure it out for yourself. Questions?
Can you elaborate for them how naloxone works and what it does, just in case they don't know?
Sorry. So it's called Narcan. Narcan's the trade name. We speak in terms of generics typically. So the mu receptors are the receptors where morphine works. So morphine, and we say opioid, not opiate. Opiate sounds better, but opiate means it came from a poppy plant. Opioid means synthetic. So that's like fentanyl, remifentanil, sufentanil, alfentanil. And the drugs that anesthesiologists abuse are fentanyl. Why? Let me answer your question first. Okay, so mu receptors are where the mu receptors are located in the brain and in the peripheral nervous system. And so it doesn't matter what the opioid is, it's going to bind to the mu receptor. And there is a competitive inhibitor. Maybe you learned about this a little in biology. Competitive inhibitor of that is naloxone. And you need a lot. And it's magical if someone is overdosed, or maybe I gave someone a little too much pain medicine and they got rid of it. If they start getting a little sleepy, they stop breathing. I'm giving a little naloxone, wake up. So it is a competitive inhibitor of the mu receptor, and it is has a greater affinity, which is better. I had a small side comment on opioids. Oh, drug of choice. Okay, anesthesiologists abuse drugs. I am handed hundreds of dollars of drugs every day. I use fentanyl all the time. And the way anesthesiologists abuse drugs is anesthesiologists are very good chemistry students, and they understand that fentanyl is lipophilic. Have you ever heard that word? No? Lipophilic is lipophilic. Okay, it's absorbed in fatty tissue. Morphine is hydrophilic, dissolves in water. Okay, so what kind of lipophilic neural tissue do I have access to so I don't have to get involved with injecting my veins? It's that obvious. Anesthesiologists do abuse drugs by eye drops. And so we don't have to talk about it, but in my field, we are on the lookout for abuse. And there used to be, let's say you got caught using, you would go to special doctor rehab, it's in Florida, and then you would come back. But I know of 2 cases where that failed, and now there's the 1 strike, you're out. 1 strike, you're using drugs, monkeys can't sell bananas. You are not going to doctor rehab. You are either becoming an occupational medicine doctor, you're gonna retrain, you might become a lifestyle physician, but you will never have access to opioids because you can't. The addiction is too potent. And we usually present as dead. So, it's a little bit sobering, but we need to be prepared for the opioid epidemic, because who better? We're the guys that resuscitate you all the time. Why not do it at home? So we all carry naloxone. I don't even think my kids know this. Ask Aviva if I carry naloxone. She's but I told you. I want to talk about airway, but I want to go through some of your questions because I couldn't sleep with some, unless questions now, because I want to go through some of the questions you got. Yes?
What does the process of shadowing a doctor look like?
Okay, it's tough. It's tough because you need permission and you need to be vaccinated. And the laws for privacy are really strict now. So you need to find, okay, so it would be almost impossible for you to be in an academic hospital because the barriers and the restrictions. My husband tried to do this and caused a big problem. You would have to shadow in an ambulatory surgery center, which is not as regulated, or in your pediatrician could bring you into the office because they're not as beholden to the hospital rules. But you find a doctor, you say, hi, this is what I want to do, can I shadow? But there's paperwork involved. Like, it's a very formal thing. It's informal when you get yourself a mentor, but they're on the hook, and they are going to be signing paper like 50 hours with me, did this, that, and the other. Yeah, so some people will typically divide it between 2 specialists. 50 hours is a lot. Good question. That didn't exist when I was applying, but it's important. You have to do it. My eldest wants to be a dentist. She has to shadow too. There's one over here. Yes?
How do you prepare to be under anesthesia? Like, if you know you're going to be under anesthesia, like, how do you prepare for that?
The perioperative surgical home. Yes. Oh, okay, so we know that if we do something called prehabilitation, if you're not walking, well, let's say you're a geezer, you need to get walking. If you need to lose weight, you're gonna try to lose a couple of pounds. In fact, for bariatric surgery, which is the weight loss, they require it. Shrinks the liver, and a lot of good things happen when you lose 10 pounds. I obviously have not been successful with that. So, you know that like you're not supposed to eat before you have surgery. Do you know why? Why? Because you know why. Okay, okay, you answer it. Why don't you eat before anesthesia?
Like if you're ever to like choke or something, or like throw up, yeah, it would like get stuck in your lungs.
Yes! Yes! Why is it gonna get, like when you vomit, like if you vomited, do you get stuff in your lungs?
No.
No. But if you're under anesthesia and you don't have airway reflexes, so now you've got Kung Pao chicken in your lungs. What is the pH of the stomach? It's an acid. Okay, and what happens when you take an acid and you put it in the lung tissue? It dissolves it. It's called aspiration pneumonia. It could kill you. And so there are a lot of things that we do to prevent aspiration. We could talk about it. Like intubating cookie, we would require some things to prevent aspiration. But we can talk about it. Yes?
I'm sorry, I was just wondering, why would you throw up during anesthesia?
Because you have food in your stomach. And so you're asleep, but it's not asleep like you're going to bed at night. It's really deep. I'm putting you in a coma, okay? You're gonna relax the lower esophageal sphincter, the one that's between the stomach and the esophagus. And then all the other tissues relax. And it is a conduit, and maybe I should just go to the picture. My pointer. Okay, so look here. This is the, okay, so you know how like if you're eating and something goes down the wrong pipe? Yeah, it's in the trachea. You're in the airway. I'm all about airway. So here you have trachea. Okay, windpipe. Notice this nice endotracheal tube. Goes through the vocal cords. You're in the trachea. And then it bifurcates into two different lungs. You want to be above the bifurcation. You don't ever want to ventilate one lung. It's not good. But look what's right behind you, right here is the esophagus. And so it can vary, whatever contents are in the stomach can vary. Oh, I didn't want to do that. Let's do one of this. It is very easy for the contents to come from here to here. And sometimes it happens silently and I can't see it. I'm lucky if, let's say it was, huevos rancheros and here it is. I might be lucky enough to see it. What does that mean? I'm looking at eggs. I can't see. I have to put a breathing tube. I gotta go through the muck. Not good. Not good. So you put the two here. So they're very close together. So that's why it is very clear. Fasting before anesthesia is very important to make sure that there are no stomach contents. Some diseases like long-standing diabetes can cause delayed gastric emptying, and under the best of conditions, has it happened to me that you go to intubate somebody and then they go, rah. Yes, yes. Oh, I got a lot of questions here. Okay, first.
What's the most challenging part of being an anesthesiologist?
Waking up in the morning sometimes. I'm tired. No, because listen, split seconds matter. We act fast, but we're trained. Like we are like a hitman, like we know what to do. We don't even have to talk to each other, we know. And we always help each other, always. It's not a team sport, except when it's a team. And one of us is in trouble, everybody helps. There's no ego, everybody helps. Yes?
What is your favorite field to collaborate with?
That's good.
Like, besides, like, is there any, like, field that you're just particularly interested in that you like to have conversations about that's not anesthesia?
Well, I am forced to discuss neurology a lot. maybe my husband will come and speak to you, but he's boarded in I'm boarded in 3 things, medicine, anesthesia, and pain, which is a little weird, but he's boarded in 5 things. He's also an incredibly good test taker. So if you were to ask my children, apparently we speak another language. They're like, oh, they're at it again. Like if he has an interesting case or something. So I like medicine. Like I like sick. It's cool. I don't have a favorite. Psychiatry kind of for me is a bit of an eye roll because patients don't want to be psychiatrically ill. They don't. But we don't have good enough tools yet. There's psychiatric illness in my family. And I, for a long time, used to do anesthesia for mentally challenged. Okay, so there are people in the world who are have very low IQ, they're so, they cannot sit in the dentist's office, but they have teeth. What happens? They come to Westchester Medical Center where I was working, and they need general anesthesia in order to get their dental work. But where am I going to put the tube? All right, so there's no, you can't even get an IV in them. That's a challenge too, but we have tricks for that. It's all about tricks. And it is also about never having one way of doing things. There are about 5 ways of doing it, and if you ever ask an anesthesiologist, how would you do X, Y, Z, the answer is always, it depends. So, let's say I'm going to intubate in the usual conventional way, and I have this big honker tube in the mouth, but I'm working with a dentist. Not good. Yeah. It's in the way. You go through the nose, crunch on the turbinates. It's a different technique, but then it comes in, and then the mouth is free. Other questions? Yes?
So I have, why are there different types of anesthesias for different types of surgeries?
How much time do you have? How much time do you have? Okay, it's 4:45, it's 10 to 5. All right, okay, so for example, let's say you were gonna have a baby. Okay, I'll give you the scary case of you're gonna have a baby. Okay, let's say you come to the hospital and have a baby and you are afraid of an epidural because you want to deliver your baby naturally. In my world, epidural and no makeup is very natural. Epidural is safety. Why? Because you're laboring, you never had a baby before, you don't know what's gonna happen. And then you find that it is very painful. But the baby is in distress. I don't have an epidural to help you. I have to get you to the operating room quickly to get the baby out. What am I doing? I'm gonna intubate you. Pregnant women are very high risk for aspiration. They are by definition a full stomach. Yeah, that's scary. So you'll hear that women deliver C-section. They are stone cold sober. Stone cold sober. But they are numb from the waist down, usually with a spinal or an epidural that's dosed with different medications. And I'm at the head of the baby, chatting them up because the surgeon, the OB is going to tell you what they're going to do, and then you're going to hear a baby cry. So, yeah, okay, what about different types of, okay, shoulder operations are very painful. Shoulder operations are routinely done with a nerve block. There's the interscalene plexus over here, routinely, that arm is dead. And then the LMA, I have an LMA here, you put in the LMA, ventilator, happy. And then when they wake up, they are pain-free. You say, oh, you done? Can you open your eyes? Do you want me to take care? And then they get to the recovery room, they're like, I'm done? Yeah. And that happens every day. Fun. So it depends on the kind of procedure. Okay, I'll give you children. Okay, let's say you want to anesthetize a 4-year-old, really scary. It's the old 4-year-old, okay. There's a tube here that you could use for a 4-year-old. Is a 4-year-old gonna allow you to put in an IV? No. And children have a very bad habit of doing something called laryngospasm when they get freaked out. So laryngospasm is the vocal cords clamp shut. I cannot overcome vocal cords with a strong arm and an endotracheal. You cannot. You have to break it with succinylcholine and you have to paralyze them. But wait, you don't have an IV. and you have a child who is immediately turning blue, who has vocal cords closed, and you've got nothing. We do it differently. They're always two parts. So one size does not fit all. It depends on the requirements. Does that answer your question?
Yeah.
I think there's one thing here. Yes.
Okay, I have 2 questions.
Okay.
Did you ever have like a light bulb moment where you become a doctor with your
I was 7.
Yeah.
I wasn't an astronaut. I wasn't a teacher. I was like, I'm going to be a doctor. I just knew. And my husband the same. Like, there are no doctors in his family either. You just know. You just know. And yeah, you just know. And it could be that I want to be a nurse too. It could be I don't want to do all of that training and maybe I want to be a physician's assistant or a nurse practitioner. But you just know. Like, these kinds of problems are interesting. And these kinds of connections are interesting. And then the rest is in the details. But the first path is, yeah, I like taking care of people. Yeah. Like, I don't want to be their computer science guy. Like, it's good work too. I don't have those skills. Yes, or you had 2 questions.
My second question is, did you ever consider like opening your own private practice?
Yeah, but you have to have a business head for that, and I didn't want to waste my time doing that. I want to take care of people. I like training the next generation. It's not for me. I could have made a lot more money that way, but I would also point out to you that nobody should ever go into a specialty because you think you're going to make a lot of money. You'll always make enough money, but you got to do what's going to be interesting because you're going to be spending a lot of time, a lot of long nights, it's a lot of time. You got to do what you like, and then you will be compensated. Okay, we have one more over here, and then we have another. Okay, Ms. Argyle Sweater, hold on. One more here. We'll go.
What would happen if you gave someone too much anesthesia?
I would reverse it.
How would you do that?
With reversal agents.
Oh.
Yeah. Yeah, we reverse it. If I have you paralyzed with a rocuronium, and then, surgeon says, we're done. Oh, no, embarrassing. I give you a reversal agent. It's called Sugammadex.
I have another question.
We also have, the way we are, and I am like this when I'm cooking too, you can always give more. You can always give more. And sometimes there's a normal distribution in terms of response to medications. So sometimes you overdo it. You just reverse it.
Can you be allergic to anesthesia?
Oh, for sure. Oh, for sure. But you avoid it. And if you're allergic, I know how to treat it. Quickly. Put in a breathing tube. It's the first thing you do. Secure the airway. If someone is having an anaphylactic reaction to, or let's say you gave the antibiotic before the surgery, it's usually penicillin-based antibiotic, and all of a sudden, they're red. Ooh, there's a new rash. That's a problem. But the patient is asleep because I put it in the breathing tube and I gave them some answer. I know what to do. Because soon, if I don't, their blood pressure is going to be on the floor, or I'm going to have very high pulmonary pressures because if they were awake, they would be going, but they're under anesthesia, so they are silent. But my monitors are going to show me that the high pressure, you know what to do. But we train for this. We train. We train. Yeah, there's nothing really new. Okay, this side of the room, yes.
So 2 small questions. So what's the most interesting surgery you've ever sat in on and watched, and what's the longest you've ever been in a OR with a patient?
Well, we have rules. Okay. One night I was on call overnight at the Brigham with a trauma, and it was daylight savings, and it was the one where you add the hour, and I had to document 2 a.m. Well, the most interesting was a Siamese twin separation at the Children's Hospital in Boston when I was a resident. Why? There were 2 anesthesia teams, right? They were Siamese conjoined twins. This was going to be a 36-hour operation. There was the red team, there was the blue team, and you needed, because the circulations were complex. So that, I would say, is definitely the most interesting. I wanted to tell you, because I was working with a surgeon today, and I asked him some of the questions that you had asked me. And I have to tell you what well, first I want to tell you about a case. I worked at Westchester Medical Center for a really long time because we deal with ethics. Okay, so let's say you're in the hospital and you're very elderly and you're very sick and you have a designation called DNR, do not resuscitate. But you know, you're kind of doing your stuff and maybe you're getting some fluids and you're getting some antibiotics, but now all of a sudden you have a bleed in your stomach and you need to come to the OR. It's rescinded. Because if you're coming to the OR, I'm gonna resuscitate you. So I think that was one of the questions, one of them was challenging. So there have been many challenging cases, so many. But I was thinking of one, which is I was at Westchester Medical Center, and if you work there, the police bring you your patients. And it was kind of late in the day, and the police brought in somebody, and he was handcuffed to the stretcher. And there's a little bit of excitement because one guy's got the gun, and then the other officer always comes into the operating room with him, and we typically watch them because they faint. And I didn't care why this patient was in a high-speed car chase with the police. I'm just thinking, broken leg, must go to the OR, broken leg, how am I gonna do this? But the nurse tipped me off about his crimes. I didn't like this at all. They were against children. So I had to step away. He did that much worse. I could really hurt this guy. And so I walked away. I was like, oh, you know, I'm just gonna check the room, make sure we're ready. And I was like, what am I gonna do? Okay, so how could I hurt this guy? All right, how do you intubate? You have an IV. I give you a medicine that makes you forget, right? It's usually a Valium kind of medicine. And not only does it make you forget right now, it makes you forget a half an hour ago. That's nice. Then, I'm gonna give you some oxygen, and I'm going to give you saw that white syringe, propofol usually. It's an hypnotic, right? It could be pentothal, it could be propofol. You're asleep. But then once you're asleep, I check, I make sure I can ventilate, because you don't ever want to be in a situation where you can't intubate and you can't ventilate. I can ventilate. And then I paralyze you. So I had some thoughts about paralyzing him first. I put the tube in. I could do it. Why? Hippocratic oath. Yeah. Right? The Hippocratic oath, first rule, primum non nocere, do no harm. But that it still stuck with me. When I was asked that question, I was like, oh yeah, that guy was bad. It was really, really bad. But you do the right thing. He didn't thank me. He doesn't even know what happened. But he got his leg fixed, and justice was served, I hope. There was a question, and I had to ask the surgeon I was working with today. There was a question about what do you do if you dread the long spooling? Have I answered that? But what this guy said, he's a vascular surgeon. He's like, you gotta approach, this is what he would tell you. You gotta approach this, if you're gonna get on this path, you have to think of it like you are a race car. And you're always thinking about the next turn. Just think about the next turn and navigate the next turn. Don't think about the finish line, you're gonna get there. But just navigate each, and I thought that was really smart. He wanted me to tell you that. Someone else asked about if you don't like blood. Okay. So my answer for that was radiology, occupational health, pathology, psychiatry. And then so I told him, I asked him the question. He said, oh, well, when I was in college, I was watching a movie with my parents and they were talking about neurosurgery and they were describing the operation and the burr holes and this and that. And I got up to get a drink of water and I fainted. And my very dutiful immigrant Italian parents said, Mike, get up, you're supposed to be a doctor, what are you doing? You get over it. You get over it. If it's what you're supposed to do, you will find a way. Are there other questions? I see this side of the room. Okay, yes.
I was going to ask a question relating back to when mothers give birth, and when you said that a lot of people think that when they don't want to have anesthetics because they think it's a not natural way of giving birth. Does it have a direct impact on the child?
Yes, they're healthier and safer Because if you have a woman who is possessed by the devil and shrieking in pain, her heart rate goes high. Why is my kid calling me? Leo, you're picking up? Okay, good. Okay, so you're possessed by the devil, it hurts. Your heart rate goes fast. The baby's heart rate goes in. A normal uterine heart rate is 150 beats per minute. They go at 200 beats per minute. And you know what happens when these little itty bitty babies' heart rates? Their pH goes low. Their pHs are low. That is not good for the brain. No way. But there are a couple of myths about labor epidural. So one is it prolongs labor. Yes, it prolongs the delivery by 15 minutes in the aggregate. That means some get comfortable, the baby's delivered. Some, it might take longer. The other is back pain. There are no studies that show long-term complications of low back pain with an epidural. Short-term, yeah, this is a big needle. It's a big needle, and you thread a catheter into the neuraxis, take the needle out, big needle. I noticed it, but it goes away. But, so if you have a mother who's shrieking and unhappy, and in 8 minutes you have her now like watching Netflix, the baby's calmer too. And then if that woman can deliver a baby and it only feels like pressure and they have no pain, she's calm, baby's calm, it's better. Are you asking, do the local anesthetics that I put through the epidural catheter into the neuraxis cross the placenta and get into the baby? No, because it's a big molecule. Can't cross the placenta, no. So, you know where I stand when it comes to labor, but the world that I live in, I see things very differently for a woman. Like, more power, there is a machismo out there about not having analgesia. I don't know, yeah, I don't buy it. But for me, I will, if I'm on the OB service, I always take a look, because if I have a parturient, someone in labor, who weighs 400 pounds and looks like Jabba the Hutt, that's going to be a difficult intubation. And if she's saying no epidural, I'm going to try to have a conversation. And, because I'm thinking 4 stages ahead, I've got 5 plans, and I'm not just, that's how we are. Does that answer your question? Okay, other questions? I made a note to myself. Misconceptions about anesthesia. We could talk about that. Clinical versus academic medicine. Do you know the difference? Okay, clinical medicine is what I do now. I'm taking care of patients. Academic medicine is you are doing studies, you're getting funded through your studies, and you're also training residents or whoever. So that's academic medicine. It's really cool. Okay, other questions? Who's younger?
No, they have questions.
Yes.
Have you ever experienced like complications with a patient like regarding anesthesia?
All the time. I fix them. All the time. Like, what kind of complications?
Is it instantaneous? Sorry. Like when like if somebody has an allergy, it's pretty quick, you know. I mean,
Yeah.
Yeah.
Yeah. I mean, what I have no control over is if in the days when we used to use a lot of opioid in the operating room, patients, like, we don't want post-operative nausea and vomiting. The risk factors for post-operative nausea and vomiting is young, female, non-smoker. Yeah, you're all gonna puke. Puke. I don't know why, but smokers don't puke. Don't start smoking. But we don't like post-operative nausea and vomiting. And sometimes anybody here, if I give you a general anesthetic, I'm gonna pre-treat you so that you're not gonna vomit. But you might be at such high risk that my medications wear off in 8 hours, and then you go home. And either you're puking because you're taking pain medicines that make you puke, or you're puking because there's still some residual vapor. You might puke. We don't like that. But all mistakes are my own, and I treat them. And it's all gonna happen now. I don't have to worry necessarily about what's gonna happen later, because if someone's gonna get sick under anesthesia, it's gonna happen on my watch. And I know how to fix it. Yes, yes.
So I have two questions. One is there like a designated time that a patient would wake up after anesthesia, and like what happens like if a patient doesn't wake up and like
Embarrassing, very embarrassing. Okay, so we're not just sitting in the OR doing the crossword puzzle. I know, I understand the surgery, I understand trocar. I need to provide the surgeon with optimal operating conditions. That means the patient isn't gonna move, right? However I can do it, patient is not gonna move. But I understand, I know what they're gonna do, and I can anticipate, like, oh, we're doing a big robot, like the picture I took of myself, that was a big robot case. We have time, so it's like, all right, take a picture, yeah, so. But I know, like, once they pull out the trail, like, oh, I'm flying the plane, right? I know, okay, I got about 20 minutes, and I adjust my stuff. So I take the patient from deeply anesthetized in a coma, being fully supported by oxygen, vapor, paralyzed. I make sure they're reversed, and then I get them breathing on their own, because believe it or not, we can breathe on our own when we are asleep. But I can only do that when they're kind of like doing the surgery. They're like, okay, so I'm like, so like, it's a dance. Like, they're doing their thing, and I'm like, okay, I gotta make sure. And then, oh, no medical student's gonna close now. Okay, we're going back on the vapor. Okay, we need more time. And then I just kind of control it that way. But I like to make sure my makeup's sort of smooth. I like, because they're all watching me. All right, it's my big moment. Intubating, extubating. And you wanna look good. You wanna look good. And then I wanna say, you know, like I can say, like, Karan, you know, open your eyes. Squeeze my hand, you want me to? And then you go out in a field of glory, because they're also looking at the time. So what happens if I miss it and you wait in the OR? Very embarrassing, very embarrassing. You're like, yeah, wake up. If they're sleeping, and everyone accepts it. But that usually happens when you're in training. It doesn't happen when you're done. Okay. Oh, hello, yes.
Have you ever had anyone die because of like complications with like surgery or something?
Yes. Yes. Yeah, it happened a year ago. I couldn't bring him back. The guy was just coming in for an upper endoscopy and a colonoscopy. He had been very sick. He had had cancer in the larynx. Anything in the larynx gets our attention. He had a hoarse voice because he had had so much radiation into him. And I was with a gastroenterologist, but fortunately I was in the hospital, not in an office or anything. And he went into a cardiac rhythm called PEA because he had untreated heart disease. And why do I know that? Because he went to autopsy, and he had a lesion of his heart called a widowmaker, which he did not know he had. Maybe he knew, but he wasn't doing anything about it, which was, he had a 95% clogging of the main artery to the heart, I think. There was nothing I could do. There were others. It happens. People are sick. Yes?
Going back to like the stomach thing.
Aspiration?
Yeah.
Yeah.
So what if like they threw up, but like you already gave them anesthetics, and like
Do I have a protected airway or I don't have a protected airway? That's all I know.
oh,
You tell me, what is your scenario?
but I don't know, but I guess I would say unprotected airway. And like, how would you be able to?
Well, I have a suction catheter. Like the dentist? Yeah, suction catheter.
Oh, so that goes also.
You suffer
Yeah. Because you've got Kung Pao chicken, or you've got, well, we talk about the huevos rancheros a lot. Yeah, you suck it out. It's a little icky. Which is why I don't wear a watch anymore. I don't even wear my rings, because it's a little icky. But you put the tube in. You put the tube. But how do you know where to put the tube if you've just, because once you start instrumenting the airway, there are secretions, Woe to you if you were not so gentle, it happens, and you got blood. You go for the bubbles. Because there are gonna be bubbles coming from the lungs. You go for the bubbles, you put your tooth into the bubbles. And then you get an end-tidal CO2.
You have a question?
Do people need anesthesiology or like anesthetic, like when you're putting like a nasal tube in or like a?
It depends.
Yeah. Because my baby brother, he had a nasal tube. And
Did he have a nasogastric tube or did he have a nasal tube for breathing?
nasal gastric tube.
Yeah, different. That's going into the esophagus and into the stomach. Next door neighbor, not in the airway. Yeah, but it's a problem. Okay, but let's say I had to intubate your baby brother and he has that tube. That's great, because I know not to go there. Yeah, there's a tube, but don't go in that lane, just go, because I wanted to show you, like, the view, and we can pass these things around, maybe waste some time for showing. Don't go where the tube, don't go where the, it's great, just go above it, yeah. Oh,
You go first.
Like regarding like where you put the tube, do you have like a camera or something attached to
It's
it?
funny you should ask.
Or do you just?
That's what we're
Funny you
gonna
should
do.
ask.
Look at some of this stuff.
I'm bringing you some things that I lovingly swiped from the operating room and my personal pulse oximeter, and I wrote things so that maybe, let's just pass this around. Because it is very important where you put the tube, and it is very subtle. An opera singer is going to get that size of 602 because I don't want a trauma for vocal cords. COVID patients, ICU patients, they're going to get the 8Os.
Oh, this is the opera singer.
Yeah, it's opera singer.
So yours.
Yeah,
And they're labeled, guys.
yeah, I put some facts, fun facts.
Oh yeah, this one's cool. Some of you might have this.
That's my pulse oximeter. Try the pulse
Yeah.
oximeter. Okay, I wanted to make some points about the pulse.
Want to hold this?
No, just you should try it. Visual.
I'll take it out.
Yes. They're all packaged sterilely. These blades are disposable now. Pull it so the light shows. Pull it.
Oh, don't paramedics also have it?
Paramedics intubate. Yeah, this is the straight kind. That's the curved kind. This is for Cookie Monster. This Cookie Monster has one neck.
Like when you get that, do you feel like this?
Does the patient feel it? That, okay, so that would go
That looks aggressive.
above the carina. This is the carina, it feeds, this is the breathing tube that goes feeds into the lungs.
We need to do pictures with you. I should be taking pictures.
Just have me on live.
I realize.
Sit around here.
Do you guys care if I take your pictures?
Balloon,
Just like from far. Oh yes.
the balloon goes below the vocal cords and it anchors the tube. Because I can't push oxygen and stuff in if there's a leak, right? If and there are problems with what if the balloon comes? It's a mess.
Like if you push too hard.
Do you guys care if I take a picture?
If
Please do.
they're
Yeah.
in the ICU usually and they're not, and it's just plastic. Then you have to change the tube on it to feed the patient. Yeah, bad. What do? You take, it's called a self-injure technique. You take a device, you know that tube is in the right place, it's sitting right here. You take a thing, you put it through the tube, you take off that tube. And very quickly, you take another tube and you thread it over your stylet and replace the tube. Not everybody does that.
Miss Segal. She has a question.
Oh, hi, I want to give you this. Okay, I'm going to give Noah this. All right, you're the photographer. Okay, so you know what this is. No, this is the $2,000 graph that we use for COVID patients. You hold it in your left hand and take a look. Even though you're righty, you hold hold it.
Oxygen's good. Your heart rate's really high.
It gives you a lot of information.
Yours was 98.
Those blades are supposed to use them all the time. But this is the special one. Okay, so also you can stay away from the COVID patients. Because you
have to put together this here.
Oh, yes.
Mr. Melvin, email. Get some like,
tongue is here.
Yeah. And then we got to
yeah, that's what I'm saying. So we'll put together a little thing for
Yeah, so this is it's
You like stand behind their head, right?
we always stand behind the head.
Yeah, over
But this
and
is a better view, and I don't have to get as close and get a big
You
scoop
don't have to
full of
get up
COVID.
in their mouth.
Right, I can go like this, and you just line it up, and you get the. It's showing me the end. Let's see, I'm looking at corona. Yeah. But I don't have to get a suit full of COVID, and it gives you a better view because you want to intubate correctly the first time. It's your best chance. You always want to be successful the first time. You're not always. But here, so you guys just don't. It has a very long battery life. But these are some of the special.
All right, Mia, lay down on the table.